Now we have to invite Dr. Srivastava, another eminent and pioneer of echocardiography, and we are going to hear from him ischemic mitral regurgitation, pathophysiology, quantification, and diagnosis.
Thank you very much, sir, and the two chairpersons and distinguished Nandita as I see today. Good evening to you all. This is the echo anatomical correlation. Things for 3D could have not been more justified than in analysis of mitral valve. But for a mitral valve, I'm not too sure where are we as far as requirement for 3D is concerned. But 3D has really come off way in analysis of mitral valve analysis, and more so ever since mitra clip and this, that are happening. So this is what my description is. This is a short axis across mitral where there is a 2D where it almost disappears. And when you look at 3D, it translates into something which is almost real life 3D. You can almost see the mitral valve leaflets, the cusps, LVOT, RV. These are things which are so vivid in 3D. It has made its own space now as far as evaluation for mitral is concerned, and 3D reigns. When it comes to quantification, the quantification of mitral regurgitation is almost the same as that what we know for ischemic mitral regurgitation is almost the same as that what we know of in other. You have area, you have regurgitant jet area to LA area. There is, you can grade. Not only that, you have some features where you can measure the area and jet percentages. This is how you do it in 4-chamber, this is how you do it in parasternal, and this is how you do it in short axis. You can measure it, you can find out the details, and you can really quantify what is the percentage of leakages depending upon what the regurgitant jet area and left atrial area is. This is a typical grade 3, but the problem is that as we understand conventionally, BART, blue away and red towards. So if your transducer is here, if you look at this, you'll see only blue as regurgitant, but it turns and swirls. This morning we had a couple of cases of tricuspid regurgitation and mitral regurgitation where the exposition of mitral regurgitation was so dramatic that it twirled and came almost in opposite direction and started looking red, this is my description to tell that this is not the area of mitral regurgitation. Actually, if you look at it, it twirls and comes here, and this is much more than what it is descriptive of. Not going into the details of mild, moderate, severe, we know, we have lived with it. The most robust criteria for a single point mitral regurgitation is if you can document a good vena contracta. Vena contracta is nothing but a Doppler or color Doppler manifestation of non-coaptation of mitral leaflets. Mitral leaflets, when they non-coapt in 2D, you know it's a significant leakage. And when you put vena contracta, this is the highest velocity region of flow jet and is typically located at or just downstream from the regurgitant orifice. If you look at this, this is the vena contracta with flow convergence. This is the area. You measure this, and you can make some sense of what is happening to the severity of mitral regurgitation. So many a times, because of entrainment or because of high jet pressures, the area of jet of mitral regurgitation can look more expanded than what the truthful area is. Then there is PISA, more talked about, came into existence, people wrote a lot of papers about it, went out of fashion, came back again. Now, if you look at the data, they say that PISA should be done in every quantification for mitral regurgitation. Now, this is flow convergence of proximal isovelocity surface area. And if you, to give you a small concept of PISA, what is PISA? PISA is something like, this is monsoon times, you go to the terrace, and there is a drain. And when it rains heavily, this water goes and starts going towards the drain. And when it goes towards the drain, it forms hemicircular ripples. This is PISA. As it goes more towards the drains, the velocity keeps increasing. As it is towards away from the drain, it is less velocity. And the concept is that if it is more, then it is more of mitral regurgitation. So qualitatively, the presence of a large proximal flow convergence region on a color flow mapping with the Nyquist limits of 50 to 60 suggests the presence of significant MR. What do you mean by this? There is a Nyquist limits in colored Doppler, which is most of the times on the left upper corner or right upper quadrant. And if with a velocity of 50 to 60, you start seeing these semicircular different colored hemispheres, then it is known as a spontaneous PISA. Spontaneous PISA means that it is a severe mitral regurgitation for which you don't need to adjust your bars, you don't need to come down on your Nyquist limits. Spontaneous PISA means it is significant mitral regurgitation. Now this is the flow convergence. This is one of the PISA radius. There can be several with different colors, and all these mean different velocities, because this is the velocity of PISA radius. This velocity, if you know the regurgitant jet and if you know the radius, these are three things you compute. Most of the commercially available equipment has an inbuilt algorithm to find out what is the area, and it will give you what is the significance of mitral regurgitation. So this is 1, 2, 3 different. So this is R1, which has a velocity of 100 centimeter. This is R2, which is 50. V1, R3 is V1 with 20 centimeters square per second. This is the velocity of mitral regurgitation. You compute it and you get what is there in PISA. PISA should be done, and it is, you can get regurgitant volumes, you can get what is happening and severity of MR. Now, if you look at this, here is one example where I just wanted to tell you that this is a spontaneous PISA. If you look at it in this Nyquist limits is about 50, and if you look at this just below the mitral leaflets, as it goes, you start seeing that there is a spontaneous PISA, there is a hemicircular turbulence which is happening. That means it is significant mitral regurgitation. Not only that, you can see it by the jet area, and it is almost going to the pulmonary veins, so you know we are dealing with mitral regurgitation. Now coming to the ischemic MR in particular, ischemic MR can be because of papillary muscle rupture, infarcted papillary muscle, but no rupture, and close to about 3/4 of cases, which is functional MR, which is the commonest, there is MR in presence of structurally normal mitral valve leaflets and subvalvular apparatus. Now, Carpentier has given some kind of classification, but I'm just going to restrict myself to the annular dilatation type 1 and restricted type 3B, and these are the two in which world has been working so much, because these are the ones which contribute best, and it is assumed that people who have this can be corrected and people will live longer. Now, this is the cartoon next I'm going to show is functional MR. So myocardial infarction happens, then there is a dilatation, LV rebonding, there is a pull of the papillary muscle, the chordae keeps on pulling up, there is an annular dilatation, papillary muscle further pull up, this stenting occurs in mitral region and leads to a functional ischemic MR. I'll go through this cartoon again, because this is what the pathophysiology of functional ischemic MR is, and this is the thing which teaches us one thing, that central mitral regurgitations are the ones which favor diagnosis of ischemic MR rather than inflammatory like in rheumatic or otherwise. So this is what is happening. This is myocardial infarction, LV keeps on increasing again and again. There is a papillary muscle which keeps distending sideways, pull of the chordae. There is annular dilatation, papillary muscles lead to mitral valve tenting, and there is a central mitral regurgitation jet leading to functional ischemic MR. Now, people started playing with this because they thought that it was not the LVDP, but mitral regurgitation which was killing. So people came out with several things, and this is one of the coapsis mitral annuloplasty system, where they had old-time telephone types of receiver. there was a cord which was put right across the LV, and it was tightened, and this tightening was governed by the LV, which was filled up with saline, and as the saline started flowing lesser, they thought that they have done a good job to prevent mitral regurgitation. So this was a coapsis mitral annuloplasty system. This is what it is. If you look at this, this is the area of non-coaptation here. This is the cord which runs right across from the center of this there is a cord which runs right across, and as they pull it, there will be a coaptation which will come closer, and how it is monitored is by looking at the jet, which keeps reducing as you keep pulling the cord and lead to non-coaptation. So I was a part of this international fraud when we were doing these surgeries, and actually none of the patients compared to the controls survived longer, and actually none of them had a betterment as far as NYHA class was concerned also. Now, this was restricted to these two, type 1 and type 3B. And now, the new toy for the boys has come, which is known as Mitra clip. So you have to decide for Mitra clip, assess MR severity, surgical risk, expected benefit from MR reduction. Mitra clip anatomical limitation and suitability has to be. Any other surgery required, guideline-directed medical therapy on board, CRT if indicated, if symptoms persisted, severe 3/4 MR, consider Mitra clip if anatomy is suitable. Now, where is this coming from? This is coming from a data where they say that larger the functional mitral regurgitation, lesser is the survival. So if you look at these divergent graphs from no or mild functional mitral regurgitation versus severe mitral regurgitation, survival is much lesser in people who have got functional mitral regurgitation. But is functional mitral regurgitation a marker, or whether this functional mitral regurgitation is the cause for death? I'm not too sure. Because back to back, two trials were published. This was the latter trial, which is the COAP trial from America, where they randomized Mitra clip with guideline-directed medical therapy and guideline-directed medical therapy alone, and they found that the best advantage they had was in cumulative heart failure due to hospitalization. Hugely divergent graph at the end of 2 years. Not only that, people died lesser, and they said that this is an all-cause mortality which was much lesser, but there was a trial which had been published almost about 9 months before, which was called MITRA-FR. In MITRA-FR, this was a negative trial. Then the data churning started. Why did MITRA-FR fail? So MITRA-FR failed because the number of clips were different, the EROs was different, the size of LV was different. This is all what happens with data churning. And actually, when they published COAPT, they almost said that the people from the eastern side of Atlantic, they don't know how to do it, and that's the reason it didn't serve any purpose. And the message from COAPT trial was, treatment with Mitra clip by an experienced operator substantially improves prognosis, reducing hospitalization of heart failure, and improving survival, quality of life, and functional capacity. Mitra clip as an active control arm in all the trials was there. So this is something which almost says that, look, we are gods, and that's the reason, the lesser mortals cannot perform better. But there have subsequently been enough and more data which has shown that patient groups in which there was a significant clinical benefits with Mitra clip was degenerative MR, who had declined for surgery, severe LV dysfunction refractory to medical therapy, severe heart failure despite optimal medical therapy, CRT non-responders, bivalvular disease with severe aortic stenosis and mitral regurgitation, where both the things were tackled by percutaneous intervention. It is very essential that no matter where you are doing this, a heart team evaluation is must. You have to have a functional or degenerative MR. The rheumatic mitral regurgitation is not yet approved. Echocardiographic criteria for eligibility should be there. Level of risk should be discussed, shown, and there should be a sharing of the consent. Greater than 1 year life expectancy is there. So we are now looking at how to evaluate when it is to be done. So interatrial septum is very important because when you have to puncture, you have to go posteriorly and superiorly. And I'm going to show you some pictures just to tell you this is a bicaval view which will give you the site of puncture. The puncture is one of the most critical and crucial things in mitral clip. You have to find the right way, otherwise you will keep struggling for the delivery devices to be coming vertically inside the mitral group. So this is interventricular septum. And to see the superior inferior, you can go into fourth chamber. You have to have a closed valve to be seen, maximum length of fossa ovalis, ventricles in full length, and no LVOT. This is exactly what the fourth chamber is. So LVOT should not be seen. This is how you find out the puncture site. I'm not going into the details of that because this is all, when you do it, you have to sort out the things by yourself most of the times. This is central mitral regurgitation, so there is no confusion. This most probably is a functional mitral regurgitation. So you have to see for the it's actually done in a view which is known as a 90-degree view. You have to assess the mitral valve on 2D first. Then you have to set the LVOT or the grasping view at 90 degrees. No color on, with color on, those are all things which are a matter of protocol issues. This is how you do it because this is the placement of mitral clip perpendicular to the line of coaptation. It has to be right perpendicular. And for this, 3D comes in very useful. This is how you assess the mitral leaflet in 2D. We know we've done it all the time. Look at this. There is an area of non-coaptation. So that means there is a significant MR. If you take a vena contracta, you'll find that there is a vena contracta which is large, and most likely this is a central jet. Here it's huge, big-time mitral regurgitation, and now we'll start assessing it. If you look at this bar will keep changing from its assessment. When you keep rolling it sideways, you'll start seeing leaflets, which the scallops which are there. From lateral to medial, it is A1, A2, A3. Anteriorly and posteriorly, it is P1, P2, P3. So if you keep rolling your TE probe, you'll keep seeing different coapting areas. So if you look at this vertical bar and the horizontal bar, you'll see that you'll keep changing the views. So this is transgastric view, difficult to get many a times, but it is recommended. And in transgastric, what you see is area of non-coaptation and central jet. This is not actually a true transgastric. It's difficult to get an absolutely circular kind of a transgastric. And important is that if you really want to do a face-on kind of a visualization, then 3D comes in very, very useful. This is what it is. Then there are certain additional views, not going into the details of that. The patient symptom considerations are that one is that everybody's life expectancy should be greater than 1 year. They should all be symptomatic. The level of surgical risk should be higher, and they should meet the anatomical and echocardiographic criteria for eligibility. And certainly, of course, they have to have a significant mitral regurgitation. Now, these are all parameters. All of us know what are the resistant volumes like, fractions, effective orifice area. How I have remembered is 0.3, 4, 5, and that is how it should be. If your regurgitant orifice area is more than 0.3, if your regurgitant fraction is more than 40, if your regurgitant volume is more than 50, this is how I have remembered 3, 4, 5. And vena contracta, if it is greater than 0.5, these all qualify to be having an appropriate anatomy or the need for sorting out the mitral regurgitation. So NYHA class certainly should be more than 2. Surgical risk should be a little high. Then there are certain other parameters you have to measure when you are talking about specifically mitral clip or this is coaptation height. This should be there. And if the size or the length of PML is lesser than 7, you will find very little space for it to be clipped, and that's the reason why it may fail. Then there are flail width, flail gap. Not very many people are now bothered about this, because once they find that it is a significant MR where they can grasp, they'll be good enough to go about it. And when experience gains, then these things become kind of redundant. Patient consideration, I'm not going to talk. Just go ahead with the case which, one of the cases which we have done. 69 years old man, severe MR, mixed pathology, EF 40%, NYHA class 3, post CABG, post stent. These are the steps. Here there is a stiff wire which is going into the left superior upper pulmonary vein. If you go and see this, this is how it is. There is a transesophageal echo probe which is always there. Fluoroscopic guidance is a must, of course. And this is what you see. The leaflets are grasped, inserted, and here it is released. So if you look at this, let me see. Yeah, it moves. This is what the end result would be like. And when you have to check it out, best is to check it out in transesophageal echo. This was pre and this is post. So in post, there is a little bit of lesser of mitral regurgitation, though the device delivery system is still there in place. There would be some kind of a mitral regurgitation secondary to that. Once you take it out, there is hardly any mitral regurgitation. Now, not that this talk needed this, but there is one more intervention that you do in not ischemic MR, but this is paravalvular leak. Again, this is how you keep looking at 3D advantages in paravalvular. Here there is a palap going right across mitral. This is a bioprosthetic valve, which is showing some areas of non-coaptation. And when you have to put some color, you will find that there is some dramatic colors which need to be plugged. And you just plug them, and these are the holes which you need to plug up. This is, you can't see it anything better. And if you want to really see it more dramatically, put some color and you will be able to see it better. These are the wires which are going, and this is after the device placement. So this is what you are doing when the device is being placed. Let me just see where I was. This is mitral regurgitation from the paravalvular leak. No, it doesn't move. And this is the place where the device has been placed, and you can see this device, and there is hardly any paravalvular leak. So things have come a huge, big way, and from clinical impacts of 3D echocardiography, we are here in an era where there is some substantial change as is needed, and echocardiographers are making themselves more worthy in patient management. With all modesty. Thank you very much for patient listening.
Yeah, I think it's a great, very elegant presentation. What device was that in the paravalvular leak? Which one did you put? Is it a
Implants.
which one is it?
Implants.
Implants device, right. Good presentation. The quick question is, one is, as you mentioned very rightly, that coapt data is certainly different as compared to the previous one, because the technology was very primitive in the earlier stage. The understanding of the mitral anatomy was different. Now we understand mitral anatomy in a much better way. Even the clip technology has changed. Nowadays we are actually using not even one, two clips.
And larger ones, the extended
Yeah.
devices,
so many other clips
XTs,
are being
NTs.
used. So, and the valve redundancy and the what is called that gap is again not very important, because the moment to capture it, you just hold it. A quick question to you is, like you said, to those kind of parameters in ischemic mitral regurgitation, what are the validity of those parameters in acute mitral regurgitation, for example, or in mitral regurgitation with low cardiac output state?
Sir, acute mitral regurgitation is totally a different ball game. because acute mitral regurgitation, everything is entirely dependent upon how quickly you make the diagnosis, and the classification for mitral regurgitation is almost the same. But suddenly there is so much of an increased LA pressures.
Right. So there is not much of gradient between LA and left ventricular diastolic pressure. So all the regurgitation fractions, the regurgitation, these jet and those kind of
So everything
parameters
is
will change.
underestimated.
Right. How do you sort of ascertain the severity of MR in that situation?
So if there is a 2D where there is a rupture, which you see, which is the thing which makes you push the patient into the theater, is the thing that if you find that there is a mechanical issue. Second is if you see that there is a, again, mechanical issue, if it is a leaflet, if the MR is significant, that is the time, and if you know that it is an acute myocardial infarction situation, third day, fifth day, because these are the times when acute mitral regurgitation manifests the most. Then you have to have a high index of suspicion and send the patient for surgery.
And the low output state, because
Low
again,
output
the
state.
same condition. If the patient is in the cath lab with a low output state and you have to do a procedure, all these parameters may not be exactly the same, right?
Is there any role of MitraClip in DCM, the MRs that have happened because of?
So now, very good question. Why I am a little cynical when I say that there is people who have refuted MITRA FR trial is because they have their own bias for the MitraClip to succeed, is because whenever there is a poor LV, in diastole, LA and LV are a conduit because mitral is open. So 60% is almost always a part of diastole. So whenever there is a poor LV, LVDP is equivalent to LA mean. And people don't die of mitral regurgitation. In fact, you close the mitral in a poor LV, you are going to cause a disaster because that decompressing chamber you have obstructed. So I am of this opinion that mitral regurgitation, if at all, you should do it only when there is a significant need for it. Say if there is a mechanical issue, if there is a severe mitral regurgitation, where you are sure that MR is more contributory, but LVDP is the thing which kills.
Excellent. I think very well said. So in mitral regurgitation, respect hemodynamic much more than the valve itself. That determines the outcome.
Sorry? So people have diagram, but the mechanism is such that you don't release it unless you are sure. So you have to be sure with your 2D, you have to be sure with your 3D, and you have to be very sure that the clips have held the mic, and then only you release. So that way it has become a safer game. And you have all the time on you. As against TAVI, where there is so much of hustle bustle because you have to finish the procedure quickly because now the balloon is there. As against this MitraClip, you can take your own sweet time. It is not a hard pressing procedure where you are fighting for survival and complications. No, it is very comfortable. You can take 2 hours.
The 3D has changed understanding much better.
Correct, sir.
Thank you, Dr. Shamir. It has always been a pleasure to hear you on the stage, and we keep coming, please. Of course.